Before we get underway with introductions, I'd like to make a couple of brief preliminary statements. First, we would like to acknowledge that the Thomas More Institute is located on unceded Indigenous lands. The Ghanaian Gehaga Nation is recognized as the custodian of the lands and waters we now call Montreal, which has historically been known as a gathering place for many First Nations. Today, it is home to a diverse population of Indigenous and other peoples. We respect the continued connections with the past, present, and future in our ongoing relationships with Indigenous and other peoples within the Montreal community. Now, a word or two about the Thomas More Institute for those of you unfamiliar with us. TMI was founded in 1945 as a center for adult learning and shared inquiry. Every year, we offer university-level courses in the liberal arts, which aim to explore questions in a variety of disciplines and which address issues of current significance in our culture. The Institute's winter and spring 24 courses are open for registration, and these can be viewed online at thomasmore.qc.ca for those of you who might be interested. A last statement. There will be time for a Q&A after the interview. Participants can enter questions in the chat box at the bottom of the screen, and we will try to take up as many of them as we can. This webinar is being recorded and will be distributed within a week or two for anybody who is interested. I'll now introduce our panel for this evening. We're very pleased indeed to welcome Dr. Eugene Bereza. Dr. Bereza worked until recently as a family physician with a background in literature, music, therapy, palliative care, and bioethics. He studied medicine and completed his residency at McGill before pursuing a postdoc at the McLean Centre for Clinical Medical Ethics at the University of Chicago. He was actively engaged in academic medical ethics, clinical ethics, research ethics, and health policy development across the spectrum of care in Quebec through his work at the CIUSSS du Centre-Ouest-de-l'Île-de-Montréal, McGill University Health Centre, the Montreal Neurological Institute, as well as many provincial and national professional organizations. An associate professor of bioethics and former director of the Biomedical Ethics Unit at McGill's Faculty of Medicine, he taught graduate students in bioethics to students in he taught graduate seminars in bioethics to students in medicine, law, philosophy, and religious studies, and supervised their research. He also taught ethics to medical students, residents, and faculty, as well as allied health professionals. In an interdisciplinary context, his main area of interest has always been end-of-life care, with a special emphasis on palliative care and euthanasia, especially in Quebec's multicultural context. Dr. Bereza is the former director of the MUHC Centre for Applied Ethics, where he instituted an innovative program for an integrated, multi-disciplinary professional approach to applied ethics. Our interviewers this evening will be two members of the board of directors at TMI. Martin Benninger worked in the fragrance and flavors industry for over 25 years for a $3.5 billion family company in which he rose to take general management responsibility for Europe, Africa, and the Middle East, the most senior position held by a non-family member. Martin decided to retire very early to reinvent himself. He and his wife moved to Montreal, where Martin co-founded a successful small consulting practice targeted towards young entrepreneurs. He's been very active in the visual arts community as a collector and as a member of the boards of both the Centre International d'Art Contemporain and the Art for Healing Foundation. He is a writer, and his first book, In the Eye of the Wind, a travel memoir of pre-war Japan, was co-authored with his elder brother and was published by McGill Queen's University Press in 2009. His second book, On the Scent of a Continent, Memories of Africa, was released in 2019. Martin takes courses every year at the Thomas More Institute, collects antique inkwells, reads very widely, and speaks English, French, German, and Italian. Christine Jamieson earned a PhD in Christian ethics from St. Paul University in Ottawa. In 1998, she was hired in the Department of Theological Studies of Concordia University in Montreal and continues to teach courses in ethics, bioethics, Indigenous spirituality, and Lonergan studies. In 2009-2010, during a sabbatical year, Christine earned a certificate in organizational and clinical ethics working in hospitals in the Greater Toronto Area. This experience grounded her teaching in bioethics. She has published articles in the area of bioethics, including medical assistance in dying. I'm sure that this evening's exchange will be fascinating, and I turn it over to the three of you. See you a little bit later.
Thank you very much, Danny. Dr. Eugene Bereza, welcome.
Thank you.
We're here this evening to discuss a subject which is unfortunately of universal concern and interest. That is, what constitutes a good death. Christine and I are very glad to have you with us this evening, and we're looking forward to a stimulating discussion. So let's get right underway. The president of the Quebec College of Physicians, which regulates medical practice in the province, has said that assisted suicide, quote, is not a political or moral or religious issue, it is a medical issue. Do you agree with this?
I haven't, to be honest, I haven't seen that direct quote, and I think the context might be important, but let me answer it this way. At face value, no, I don't agree. It is a medical issue, but by being a medical issue does not exclude that it can also be a moral issue, a political issue, and a religious issue. Perhaps, though, and I'm speculating here, what he might be alluding to is the fact that, you know, Quebec was the first jurisdiction, the first province in Canada which really pushed through legislation to allow for medical aid in dying. And while the practice, you know, the criteria, how we do it in Quebec and the rest of Canada is very similar, not identical, but very similar, conceptually, they're completely different in the following way. When Quebec, which was the first, started the legislation, it did not do it in the context of the Criminal Code of Canada. It did not want to decriminalize the killing of people who were about to die. Instead, what they chose to do is to say, we're not thinking about that. We're not thinking about assisted dying. We're thinking about providing a healthcare service. Forget all about the repercussions of criminality. We're not interested in that. We're saying this is a health act. You know, we have standard care, we have innovative care, we have palliative care, and now we're going to add on yet another kind of medical care. So when they did this, they really pitched it as a healthcare act. And in doing so, they said, you know, provinces, as you well know, have a significant jurisdiction over health. So they said, regardless of what Ottawa thinks, we have jurisdiction over health, which is a largely provincial mandate. So we're creating a new health act, and they package its legislation that way. So if that's what he meant, then he's accurate. In Quebec, it's a legally recognized medical act, a healthcare act we provide to patients. In the rest of Canada, that's not the approach they use. The rest of Canada, the approach was to decriminalize killing in this particular context. So, as you know, the criminal code originally had 2 or 3 clauses in which said things like, you know, you can't assist somebody in dying, you can't assist their death, you can't, you know, help them out in their dying, and that would be a criminal act, liable to prosecution. So to enable medical assistance in dying to happen in the rest of Canada, they said, it's unconstitutional, those 3 things. So we're going to take them out of, we're going to strike them down. The Supreme Court struck those articles down as unconstitutional and therefore decriminalized it. So what that meant was anybody in the rest of Canada who asked for it, any provider who gave it, as long as it fit the conditions, could not be prosecuted. Whereas a few years earlier, they could have been prosecuted for murder. Whereas now, nobody could prosecute. So it was very much done in the context of criminal law. Quebec didn't do that. It was in health law. So perhaps when he said, President Kimé said, this is a medical act, he was trying to suggest, I gather, that in Quebec, we really pioneered this conceptually as a health act. So in that regard, I agree with him. I think he's technically correct. But as I said earlier, the fact that it's a medical act doesn't in any way preclude it from also having very powerful moral, religious, political, cultural components. So I think, and I'm not saying about this about the president. I don't know him personally, but I do know there are physicians, like in many other controversial areas, termination, abortions, who advocate for something. And so when they're advocating for something like this, they're going to want to try to simplify the approach and say, listen, we've had a long public discussion, we've had legislation, we've passed this, it's a health act, period, end of story. I don't think it's that simple. As you said, it continues to be controversial, continues to be difficult. And the fact that we've passed the legislation and it's evolving doesn't mean that it doesn't have still strong moral questions for many people.
Great, thank you.
Thank you, Dr. Bereza. And it's really a delight to be here with you this evening. And I just wanted, you've just identified, I think, really important difference between Quebec and Canada in terms of medical assistance in dying. I'm wondering, are there other differences that are more, perhaps more nuanced than that obvious difference? I'm just wondering if you could say something about that.
Sure. There are a few. Fundamentally, most of the criteria for eligibility are quite similar. The language, so for example, you have to be 18 or older, you have to be able to consent, you have to be, all those regular criteria. The one where the language is quite different. In Quebec, we say the law changed. First, we said you would have to be, we'd have to know that you were dying. We didn't set a time limit, but it was understood that, you weren't dying in 5 years from now. You were dying rather imminently, weeks to months, possibly up to a year. That was struck down as unconstitutional in Quebec by the appeals court. So we then said, we gave up the clause of being reasonably foreseeable death. My understanding is in the rest of Canada's legislation, when they had to do the same thing, strike that down as reasonably foreseeable, they put in language like you have to have a serious condition, but it can be a medical condition, a disease, or a disability. So many of the criteria are the same. Some would argue, well, that's just semantics. I think the semantics are important here. So we don't use the language of disability or disease or condition. We just keep the notion of you have something where you will be dying from. And the only thing that was dropped is that is reasonably foreseeable in terms of its prognosis. So that's one difference. The other difference is originally my understanding, it was that in the rest of Canada, or perhaps maybe it was just Ontario, I can't remember, to be honest with you, it wasn't just physicians, nurse practitioners were allowed to administer medical aid in dying. And in Quebec, that was not permissible. My understanding is that it will be permissible soon in Quebec as well. But originally, that was one of the other differences. And I think the third difference that I can remember is that we do not use the concept of assisted dying, okay? Or assisted suicide, sorry. We do use assisted dying. We do not use the concept of assisted suicide. And the distinction is as follows. In Quebec, we would say medical aid in dying is quite narrowly defined. It's the medical act of a physician, or in the future also a nurse practitioner, taking a prescribed pharmaceutical regimen, injecting a patient directly with a sequence of medication with direct intention of producing death imminently, typically within 15 to 30 minutes. That's not what we call assisted suicide. Assisted suicide would be understood in practical terms more along the lines of, listen, I want to do this home in privacy of my own home. I don't want to have anybody else around. I don't want to have doctors, nurses, anybody. Give me the medications. I will take them myself, but I need the medication. So write me the prescription. So the notion is I'm committing suicide at home. But I couldn't do it without you giving me the means by which to do it. So assisted suicide, my understanding, was probably permissible legally in most of the rest of Canada, but we don't do that in Quebec. It's not part of the Quebec Medical Act structure. So those are the main differences to my knowledge.
Yeah, thank you. Those are important differences. I was wondering just if you might say something about your own work. And I know that you're retired now, but the work that you did in connection with end-of-life care and with medical assistance in dying. If you could speak a little bit about your own work.
Sure. Well, in the very nice introduction I was giving, he did mention I had been trained in palliative care, originally way back in the golden era with Dr. Mount at the Royal Victoria Hospital. I was trained at that point, though, as a music therapist in palliative care. When I was doing medical school and residency at McGill, I did take extra electives in palliative care because there was a strong interest. So I had some direct firsthand clinical experience working in the palliative care unit per se. But after that, after my postdoc work in medical ethics, I predominantly became, almost exclusively later in my life, a consultant in medical ethics. But that was actually in Quebec, it was recognized also as a medical act. So I would be consulted the way you'd consult a cardiologist or a neurologist to come to the bedside for cases that presented profound or deep moral conflicts. Not all of them about death and dying, but in practicality, the vast majority did somehow touch on death and dying. So the most classical kind of paradigms would have been difference in opinion or approach between, let's say, a healthcare team and the family about a patient and into what kind of care what would be the goal of care. So two kinds of cases, paradigm cases. The first one would be where physicians would say, oh, I can still do another round of chemotherapy. We shouldn't give up here. I think, patients in poor condition, but if you let us go ahead, we might be able to give him another year or two of life. And the family saying, no, this is crazy. This is enough. We don't want to do this. Or, and we've seen this quite a bit more recently, the exact opposite, where the family says, no, you must do everything. And the doctors are saying, no, this is, you're not prolonging life. You're extending the dying process. So those are the kind of cases where I would be brought in to help understand, inform, perhaps clarify what the dilemmas were, clarify what are the parameters within which we could work, and try to see if we could mediate some sort of resolution. So I saw a lot of, frankly, a lot of suffering, not just by the patient, but a great deal of soul-searching, anguish, despair, sadness, sense of tragedy, all those tough feelings by family members. But more recently, I'd say the trend has kind of shifted. I've been seeing on a lot of cases a great deal of what I would call burnout by healthcare professionals who feel they are being threatened, manipulated, to do things which they think are completely unethical, violate their oath, and does nothing but add more suffering to the patient's dying process. So those are the kind of cases I would be very much involved in.
Right.
That's really interesting. Thank you. Well, medical assistance in dying, or MAID, has been approved by the Canadian government. Can you tell us a little bit about what are its terms and whether or not you agree with them?
So again, they have been approved legally both in Canada and within Canada in Quebec as well. But again, Quebec's legal framework is a different one. So just to repeat that point. But the criteria for eligibility are very, very similar, as I mentioned. So what are they? Well, basically, they are, you have to, let's focus on Quebec, because there may be some variations in the rest of Canada. But for our purposes here in Montreal and the rest of the province, you have to be 18 and over for the most part. You have to be a Medicare card-carrying Quebec citizen, okay? So you have to be eligible for healthcare. Why did we want to do that? Well, we didn't want to have what they called medical tourism. We didn't want, just like people before were going to Switzerland to get it because they couldn't get it here, we didn't want people coming into Quebec to get it. The not so funny joke at the time when Quebec was the first one out, and people saying, why did you put that clause in? We said, well, we didn't want to change the dynamic where for the first time in 25 years, the traffic would be going from Toronto back into Montreal, in terms of shift of migration, people coming from Ontario to Quebec to get it when it was still not offered in the rest of Canada. So you have to have eligibility for care. You have to be 18 and over. You have to have the capacity to consent. Okay, very critical. Until very recently, and it's changing now, you had to be competent not only at the time of asking for aid, but also at the time of receiving it, which brought a whole bunch of problems for us. And that is being looked at and addressed now. So the consent issue is very important. You had to have a grievous progressive illness from which you were dying. Now, originally, the condition was that your death was foreseeable. And everybody said, well, everybody's death's foreseeable. Guess what? I can guarantee you everybody on this webinar will die. We just don't know when. It's foreseeable. So, but of course, legislators don't want to put numbers to things. So everybody said, well, what does that mean? A month, 2 months, 6 months, a year? It was never legally defined. And was, again, when it was challenged at the appeals court level, that was dropped. So you have to still have an irremediable condition from which you are progressing and eventually will die from. It has to be very serious. Another criteria is you have to be suffering, but not just saying, oh, it hurts a little bit. No, the suffering context is meant to be very significant. The original words were things like irremediable. There's no way we can help you with this pain and suffering. There's nothing we can do to relieve you. But key point here, we can't relieve your suffering in a way which is acceptable to you. Key point here. So let's be clear here. Some patients conceivably could have had their pain and suffering relieved through good palliative care. But all they would have to say is, oh, the notion of receiving palliative care and hanging around longer than that, that I find intolerable. So they're off the hook. So in other words, the patient set the conditions under which it's receivable or not. So even though it's potentially reversible, they say, oh, but that's not something I want to try, then they don't have to accept that. Okay. So that was a key condition. Yeah, and that's a key one. You have to be in a state of irreversible, profound, constant suffering, which cannot be relieved in any other way. And do I agree with this? Well, for the most part, yes. I think those are kind of the generic criteria you see in other jurisdictions in the world as well. The one, I do have an issue with one of the criteria, and I'm going to say something which I know is going to be completely politically incorrect, which is probably why I'm retired. It's safer. And, you know, I'm not saying I'm convinced this is right, but my sense is the following. You know, you have to remember, what was the spirit of the intent of the law in Quebec? What was the intent of the law originally? Now, laws evolve, I get that. But the original intent of the law in Quebec, as I understood it, and I was involved in some of the initial policy planning for that, was it was meant to be an act of last resort, as opposed to a normal medical act. Choose one of the following. I want dialysis, I want surgery, I want palliative care, you know. Is it? No, you don't get, it's not one of many. It's an act of last resort. The idea is we weren't embracing medical aid in dying as an option like any other option because of all the moral questions associated with it. That's a huge leap we went from. I mean, think of it. 9 years ago, if I did this, I'd be in jail for murder charges. And now institutions are obliged to provide it. That's a huge change, right? So when they say, as far as I'm concerned, it's no longer an act of last resort. Why? Because all a patient has to do is say, everything you could offer me that might help me, good palliative care, good social services support, all those things that, let's say, we know palliative care is there for, all I have to say is, no, that I'm not interested in that. That doesn't suit me. Well, then it's not an act of last resort, is it? Because there's another resort. It's called palliative care. The second point is this notion about suffering. What's irremediable, constant, unbearable suffering? Now, the politically correct thing, and this is what I used to teach, and of course in medical ethics, is the patient, him or herself, are supposedly in a much better position to judge their suffering than an outsider, a doctor. So people would cringe at the notion, if Martin, if you said to me, Eugene, I'm really suffering badly, and I came and looked and said, yeah, Martin, you don't look like you're suffering too much to me, we'd all be offended by that, right? And rightfully so. But what happens when you have a patient who's decided they want to get medical aid in dying? I come up and I'm walking by the wards, and I just happen to see, as I'm passing by, they're watching Oprah on TV, they're giggling, they're having their friends over, they're playing, I'm making this up, okay? But it's hard to say that this is a person who's in constant, unbearable suffering. But I'm no longer, as an outsider, allowed to say, oh, you said you are in constant, irremediable, refractory suffering for which we can do nothing to help you. That's not the picture I see. But I can't comment on that as a physician. That would be considered inappropriate. So to my mind, there's no checks and balances. All a patient has to do is say the right words, and we're obliged to say, well, okay, according to you, that's what you say you are. Who am I to second guess that? Well, I think we've given up a lot of a checks and balances approach there. I know in society, many of our authority figures have dropped in their power, and physicians are among those. And I'm not asking that we should go back to those paternalistic days. But my experience has been, I very much doubt whether it's any more an act of last resort. That's all I'm saying. And because there's no checks and balances, physicians can't say, it doesn't seem to me like this is an act of last resort for you. And the words act of last resort were never written into the law. So it's not a legally binding concept. It was just the intended spirit of the law, which, you can't keep somebody to.
You may have already kind of touched on the answer to this question, but I wanted to. You once mentioned that your role as an ethicist is balancing the extremes between what you call the tyranny of absolutes and the abuses of relativism. I'm wondering if you can unpack these two extremes and speak to what the balance is in a situation like medical assistance in dying.
Sure. Okay, I'll try. These are basically, now we're entering into a realm of almost pure philosophy, right? And I was really privileged and blessed to have been, taught by people like Stephen Toulmin. So it was great to have those insights and teachings. The tyranny of absolutes, we seem to be living in a world which is, as you see everywhere now, increasingly polarized. There's no middle ground. It's black or white. You're either for me or you're against me. You're good or you're evil, right? The gray zones are not there. So how does that translate into what we're talking about? Well, so if you think or you believe that medical aid in dying is basically, from a philosophical point of view, a profoundly immoral act, right? At the end of the day, no matter how you splice it, how you package it legally or whatever else, you are actually performing an act to which the person dies. Under other circumstances, they would call that killing, but killing has such a negative, pejorative connotation that we don't call it killing. So, but you have a profound objection to that happening, right? So you say under no conditions, and that's the key word, no conditions. It's an absolutism. Under no conditions should we ever do that. I mean, the number of physicians that I've come across who will, get very upset because that's how we're trained. That's their belief system. That was their vocation. That was their calling. That was their medical ethic. Don't ask me to kill my patients, right? Under any circumstances ever. We should never do that. We're there to save patients. We're to keep them alive, not to kill them.
Well, the Hippocratic Oath says do no harm, doesn't it?
It says a whole bunch of things, depending which ones you want to pick selectively and how you want to pitch it. So, what we'd say is even in the palliative care literature, and of course, many, and I appreciate this a great deal, having been trained in palliative care, the palliative care literature that I remember used to demonstrate just how effective good palliative care could be, right? However, nothing is 100%. So even within the research within palliative care, there is, depending on the study, anywhere between 2 and 4% of palliative care patients who were not adequately palliated. That means they were suffering tremendously. So we're saying, well, too bad for you, eh? I mean, if you're suffering tremendously and medicine still hasn't come up with a way to managing that, well, I guess you're just going to have to suffer. And I find that kind of absolutism very difficult. It's hard, even for a physician, let alone family members, to stand at the bedside of somebody who they love, who's in their end stages, who's suffering tremendously, and all the best palliative care isn't able to somehow manage that well. Now, those are at a really extreme minority of cases, I grant you that, but they exist. Active last resort. But an absolutist would say, no, never. But I would consider that a tyranny. You have that moral value and you're imposing that on everybody. And even the most vulnerable, suffering person therefore doesn't have access to something because you have this position that you will not budge under any circumstances. So that's a kind of fundamentalist approach to things, in my opinion. But the other extreme is we have to be careful. And somebody said, well, if you don't have these strong principles, you will quickly devolve into relativism, depending on the time of day and who's pressuring you and how much money they offer and all these other things and how well funded the healthcare system is or not, or how tired you are going to find a way to justify or not. And that's relativism. And we know the dangers of relativism. Well, I don't think, yes, there is a big risk about relativism. We see that with some of the most notoriously fabulous criminal lawyers, where you can get off somebody who's clearly guilty by anybody else's standards, but you couldn't prove it, right? So because you find a way of relativizing it. Now, therefore, I detest that kind of relativism. In the same way I detest the tyranny of absolutes. What it requires is finding some reasonable middle ground that makes sense, but that requires a moral judgment call. And I think we happen to be living in a time that's this zeitgeist where, oh my gosh, why should we trust anybody but making moral judgment calls? We want recipes. We don't like grays. We don't want to say, we want a yes or a no. I mean, the number of times in my consult, people throw up their hands, just tell me, can I do this or not?
Yeah.
It's not that clear, No, we're going to have to make a moral judgment call. In this case, with these conditions, under these situations, with this prognosis, with this amount of suffering, what do you think we should do? What are the real options? Don't talk to me about the theoretical ones. What are the real options for this patient, this family, this clinical team? And let's make a judgment call and accept the responsibility for the moral consequences of that. But that seems to be a hugely unpopular approach these days. So that's the best way I can describe it, avoiding those two extremes.
Yeah, no, thank you. That's very, very interesting. And I think in some ways the title of our seminar is What Constitutes a Good Death? And perhaps you've spoken a little bit about that in your last question. And then, you've done much of your career, you've worked with people faced with, faced with the reality of dying and families dying, their dying loved ones. And I'm just wondering, what would you say constitutes a good death? I mean, from your experience, not of dying, of course, but of being around people that are dying. And, is it all about suffering, or are there other dimensions that might play a role?
It's a very, it's a complicated issue, which is why we have so many questions. And what is a good death? And my experience, it is not only as a clinician in the kind of work I did, but as a family member. My parents have passed away. Some of my dearest friends have already passed away. So I've had intimate, personal experience as well as professional experience with it. I don't think there is a perfect answer for this. I don't want to kind of denigrate it by making a joke, but I don't know if it was Woody Allen or somebody else said, I'm not worried about death. It's the dying part I don't want to stick around for. Dying can be messy stuff. So I don't know. I think a good death is, in this case, I'm going to contradict what I said earlier, is probably best defined by each person differently. What's a good death for me? Might not be the same criteria as it would be for other reasonable people like you who could reasonably disagree and still have good, appropriate concepts of a good death. But I think maybe the more pragmatic way of answering you is, I think while I can't proscribe what is a good death, I can certainly tell you what a bad death is. I've seen lots of those. And to me, a bad death is when, it's not simple, but when patients are suffering at many levels, and I'm talking about not just physical suffering. Actually, when you do studies on patients, that's not their number one concern.
Yeah.
The number one concern seems to be control. Control over how I will die. The psychological feeling, I don't have control over me. You guys decide what you're going to do to me, how many tubes you're going to stick in, where and how long. I want to have control over me. So control seems to be a larger issue for many patients. So for patients who feel they need that control and feel they lose it, well, that's not a nice way to go. And so it's not just physical pain and suffering, it's psychological suffering. It's for those who believe there's spiritual suffering, there's existential, there's all kinds of different levels of suffering. And we won't go into that tonight, but you can imagine somebody at many levels not having had time to perhaps do the work they had to do before they die and regret that. So those are sad and they're tragic. But one last note I would add on that in terms of what is a good death. And I learned this, in fact, under Dr. Mount's the unit where I was trained. We were so in the early days, right? The very first years of palliative care in Canada, we were so determined to prove ourselves, to show we could really make a difference and provide a good death to patients, as opposed to, leaving them on oncology floors, getting 17 rounds of chemo, whatever. Kubler-Ross's famous book with the 5 stages of dying. And we wanted so badly to have everybody have a good death. We were insisting people go through the 5 stages of dying. And if somebody skipped the stage, we got very upset. No, you skipped stage 3, you can't go to 4, go back to, it was ridiculous. And I guess what I'm trying to say by that is we learned the hard way that you can't fix people's problems for them. Not all of them, not the human problems. So I guess what I'm saying is, if you're a miserable human being who's had a miserable life, who's alienated all your children and family members and friends, and you're just the worst human being on earth, and you're miserable and lonely and in distress, pretty hard to give you a good death if you had a lousy life. So I'm just saying, we're focusing so much on the dying as if that's a separate issue, not related to our living. And I think people who live well probably are in better position to die well. People who have lived horribly and miserably by their own volition, I'm not talking about people who have been suffering from the outside, pretty hard to get them to have a good death. They're lonely, they're miserable, they're distressed, nothing you do helps them. those are the tough ones.
Yeah, interesting. Tell me, Dr. Bereza, when the patient who's obviously dying is not compos mentis, who is authorized to make the life-ending decision? Is it the doctor? Is it next of kin? Is it some sort of government instance?
Well, okay, so first we have to clarify. So when you say compos mentis, they typically use the term in Quebec or elsewhere is whether you're competent or to make that legally competent.
Right.
And we need to make a distinction about, there's a huge difference on that answer as to whether we're talking about ways of providing death other than MAID. For example, withdrawing life support, right? I stop your dialysis, you die. I disconnect your ventilator, you die. There's other ways to allow you to die without MAID. For those, when you become incompetent, there is a legalized hierarchy of who gets to speak on your behalf. Okay, and that changes from jurisdiction to jurisdiction. So in Quebec, for example, if I become incompetent and I'm in a hospital and they want to know what to do with me at the, should I continue, should I not continue, and I can't speak for myself, their first job is to look whether I have a registered advance directive where I spelt out what I want or don't want, and that would be binding. After that, typically it would be the spouse, and then other family members, and then close others if those people aren't around. And there are tweaks between different jurisdictions. Now, if we switch to medical aid in dying, which is a whole other category legally, right? At present, or up till now, I think, or very recently, you had to be competent to receive it. So whereas my wife could say, pull the plug, don't tempt her, she's listening. So she couldn't say that for medical aid in dying. She wouldn't have, for medical aid in dying, she would not have that authority, that power. So until very recently, only I could make the decision for medical aid in dying. Now so that's a big distinction, okay? For stopping care, which will help you die, there's a hierarchy. For medical aid in dying, there was no hierarchy, it had to be you. Because we saw some unanticipated and unintentional negative consequences to that. What we saw when I was on the commission was, unfortunately, a few patients who were competent when they asked for it. Say they were at end stages of dying, they had a few weeks left to live, they're on a cancer ward and they were suffering terribly. And so they were receiving a lot of medication for their pain and they're often unconscious. Sometimes they reached a point as to, yes, they wanted it, they filled out all the forms, it was a go, green light. But when it came time to providing it, they were already incompetent. It's a no-go. You had to have been competent at the moment of receiving it. And so unfortunately, there have been a number of documented cases where patients chose to forego palliative medication. They preferred to suffer tremendously in their last days so they wouldn't have their sensorium clouded by morphine or everything else, so they could still be competent at the moment so they could get it. I mean, that's a paradox, was not intentional, but those were happening. You say, whoa, this is crazy.
That's amazing.
Yeah. So, I mean, I don't want to go too far with this, but I sometimes think the people who write our laws aren't the ones who are at the bedside and are aware of all these nuances and didn't anticipate those things.
Right.
But suffice to say that because of that, I think there are changes that are very imminent or coming, whereby there may be some allowances for advanced directives now for medical aid in dying, where there may be some allowances for others to have a say at the end, but that's still to be verified and find a way to do that functionally.
So as things stand now, is there necessity, does there exist a written procedure for
yes. In Quebec, it is a highly regulated, I would almost say highly bureaucratic procedure.
Okay.
this is not simple. We're not going to make it easy for you. I mean, and largely because we want to make sure it's not abused. We want to make sure it doesn't suffer. So don't forget, Quebec is the only jurisdiction in the entire country which has an oversight body, which is the commission. We have to review every single case to see whether people played by the rules. That doesn't exist in the other provinces, right? So yes, in Quebec, there are forms physicians have to fill out. The first physician does a second, there has to be an independent second physician has to do the assessment. Those have to be filed. A copy has to be going to the council of physicians. A copy has to go to the commission. You know, it's a very rigorous multi-questionnaire form that asks a lot of questions to show that the proper evaluations were done, that the proper procedures were done, that the proper protocols were used. It's a highly regulated procedure in Quebec.
And who at the end of the day signs off and approves a request?
It's the patient has to sign the request, right?
Okay.
Yeah, if I don't have your name for it, I don't have any proof that you asked for it, right?
Right.
So it's like any other contract in a sense. I have to have proof that you wanted it, and hence you had to be competent. And then each evaluating physician has to sign off on their evaluation. So you have a patient's signature, you have the two physicians' signatures, and then it's a go.
Okay, right. Thank you.
I wanted to bring up the issue of palliative care. And I'm thinking about the work, and you've mentioned this yourself, palliative care as it was envisioned by Balfour Mount. And there was a concern when medical citizen dying came into effect in Quebec that palliative care would be minimized. And so I'm wondering, do you think that that palliative care is still offered in a robust way, or has it suffered? Has it been diminished because of the medical citizen dying law? Has it had an influence on palliative care, you know, in the sense that it's diminished it, or possibly even put more of a focus on palliative care because it's dealing with that end of life issues? What's your sense of that?
Well, that's $1 million question. I wish I had a good answer for you. I'm not aware. That doesn't mean it's not there, but I'm not aware of any good, rigorous, large enough studies that give us evidence one way or the other. Everybody has their impression, but very few are able to come up with numbers to prove it one way or the other. So another way of saying it, I haven't seen any convincing evidence that medical aid in dying has somehow undermined palliative care. That was the claim, but either it hasn't been studied yet, so maybe it is there, we just haven't studied well, or it has, so there's no proof that that has actually happened. Now, we've had it around for quite a few years now, so you figure if that was obvious, there should be some way to demonstrate that, and I haven't seen that demonstration. So I think, to be honest with you, my sense was that was more of an ideological argument than a numbers-driven statistical evidence argument. But having said that, I would say, and again, now this is just an impression. I also don't have any backing for this, but just from my experience, and that's all it is. I was never really personally convinced that the government, doesn't matter which regime was in power, ever fully endorsed and funded palliative care in a way I think it should have been. I mean, people have been begging for more palliative care access, good palliative care access for forever. And it's really tough to get that. Communities, as you know, have set up their own hospices where large portions of their budget comes from donations. There's some money coming from the government, but communities have had to get together and get donations to give people access to palliative care. So I think palliative care has suffered and probably still is suffering, but I think that was happening even before medical aid came in the picture. Remember that the Bill 52 the original Quebec law, which provide for medical aid. I mean, Bill 52 was not just about medical aid and dying. Bill 52 is called the End of Life Care Act. And in that same act, there was a new requirement, a legal requirement for institutions to be able to offer access to good palliative care. Now, you could argue that that was strategic, saying, don't worry, it's not going to affect palliative care. We're now obliging institutions to provide it. Institutions that didn't have access, that couldn't provide access, now will have to. You know, it's easy to write that into legislation, but if you look around at our healthcare system these days, and I think we're all painfully aware it seems to be on the brink of implosion, where are you going to cut corners? I'm not aware of huge influxes of funding for palliative care. So I'm not going to go so far as to say I think that, you know, medical aid and dying has taken resources away from that and somehow undermined. I actually don't believe that. I haven't seen it. But I do think that palliative care, properly done, could be doing so much more. And I am sorry, I don't always say this, but I think I take with a large grain of salt when we have certain politicians telling us, oh, yes, you know, we fund palliative care. Oh, yes, it's available. Oh, yes, it's this. And you can get this here at the CIUSSS. And when you're on the front lines and you see how people are dying, you know, the access to great palliative care, home care, because you have a program in a small institution doesn't mean you have good palliative care.
Right.
I had a consult not that long ago where we wanted to discharge a patient to another smaller institution, like a CIUSSS, and with a prescription for palliative medication prescribed by a palliative care physician. And we found the family phoned us back in a state of shock because the physician, it was only one physician, it was a small institution, refused to fill that prescription and provide the morphine because this physician had no clue about what palliative care was. And he said, oh my gosh, I'm not doing this. I don't kill my patients. You know, so all the fact that this was only 15 miles away from the epicenter of excellence of palliative care in Canada. So to say palliative care is well known and readily available and great, I don't buy that either.
Yeah.
Right. Okay.
Yeah.
How does a physician evaluate the patient's sincerity in wishing to die? What are some of the deciding factors and guidelines? Because it's a pretty tough decision to make, and you know, you don't have much input to go on.
Well, this is again the question which I raised, which I pointed out you raised earlier, where I said that was the only one of the very few criteria that I didn't agree with in the list of criteria, right? There is a sense, even in the original legislation, that as a physician, the physician is required to verify that the other criteria are met, right? You cannot provide medical aid in dying if the patient isn't 18 or older, if he doesn't have a Medicare card, if he doesn't have a disease that's, you know, he's going to be, all those things. One of the things I have to verify is that they're in a state of huge suffering that I can't mitigate any other way. Well, how am I going to verify that without making a judgment call on that?
Right.
What they mean by verifying is you got to check that the patient said, I can't cope with this suffering and I don't want any other interventions except medical aid in dying. Okay, well, he said that.
Okay.
Saying is not the same thing as being, but you can understand the political incorrectness of me, Dr. Bereza, saying, wait, I don't think you're, in your case, I don't think you're sincere. I think you're being scared. You know, you're homeless, you have no friends, you don't want to go back to the CHLD, you're terrified. And so you're asking for this not because you're suffering in a way that we couldn't help you, we can provide you better social service, all those other things. You're just saying, listen, I've decided I've had it, that's enough, let's go. So, but what I'm saying to you is that we seem to be not allowed to make that judgment call. We're not allowed to evaluate, at least that's my take on it.
Right.
You can imagine everybody's patient autonomy. How dare you? Who the hell are you to tell me that my mother, when she says she's suffering tremendously, isn't suffering tremendously?
Right.
And even if I say, well, look at her, she's knitting, she's talking, she's having her ice cream, she's chatting. My vision of somebody who's suffering tremendously and we can't palliate them is not that.
Yeah.
But I can't do that.
Right. Right.
Well, the patient has to say, well, no, those other things, those are in the idea of having palliative care is intolerable to me. Then it's off the table.
Right. Right. Okay. In fact, how many people go through assisted death each year in Canada? Do you know?
From the numbers I've seen, it's been clearly a very steady rise. There's no question. I'll give you some rough numbers. In Canada, let's say in 2019, there are 5,000, over 5,500 deaths. By 2021, which is 2 years later, there were over 10,000 deaths. Okay. In Quebec, in 2021, 2 years ago, now let's not look at absolute numbers. I think a more accurate sense is the percentage of dying. What percentage of people who died through MAID? So in Quebec, in 2021, the number of people who died from MAID was 4.7% of all deaths. Okay. Last year, it was 6.1%. And this year, they're anticipating if the numbers keep going the way they are, we're in October, it'll hit 7%. So we went from 4, and in 2021, it was 3.3% back in 2021. So we went from 3.3 to 7% in a question of 2-3 years.
Amazing.
That's a fairly significant.
Very significant.
Rise.
Yeah. Right.
I think my next question might touch upon that, that statistic of that the numbers are raising, because it's been 9 years now since Quebec adopted Bill 52. Since then, significant changes have happened with regard to provision of MAID to persons with illness related to mental health, to some minors, and to people who, when they become incompetent. So these are issues that have now been taken up and are explored in allowing these other categories to be given medical assistance in dying. Do you think that these changes are an example of the slippery slope that so many were originally concerned about? What's your sense of that?
Well, I'll try to answer it this way. For something which is profoundly morally controversial, and I think it's fair to say this is, what's a slippery slope to one side is evolution to the other side, right? Yes. So for those who, from a moral point of view, said this is a terrible thing, the fact that the numbers are going up is a clear indication of a slippery slope. Way more people are dying before, and criteria are changing. First, you had to be this, now it's this, now it's this, now it's this. So that's a slippery slope. If you're in a moral position saying, no, this is about alleviating horrific suffering at the end of life, then we're making sure that we're not, these criteria are getting charter rights challenges. How come he can get it, but I can't get it because my disease is different than his? That's not fair. So they're saying it's an evolution. We're finally giving it, we want to get it to all humans who are suffering. I mean, think about it this way. When the Supreme Court of Canada struck down the articles for decriminalizing it in the rest of Canada, I'm not saying this with certainty, but my recollection was there really only one criteria the Supreme Court really focused on, and that was unremitting suffering. We will let this go because we think it's wrong for Canadians to be stuck in a situation where their suffering is horrific, and we're not letting anybody do anything about that. Okay, if you stop there, then does it make sense to say, if you're 18, you're eligible to make sure you don't suffer horrifically? But if you're 17, sorry, you're going to have to suffer horrifically. That makes no sense to me. So I think the answer, whether it's a slippery slope or not, I don't think it's the numbers that are telling you that it's a slippery slope or the conditions. I personally don't think the age thing or the psychological suffering is the slippery slope. I've said this in public and I'll say it again. You know, as somebody who has, in the course of my life, suffered very significantly from physical ailments. I mean, I've gone through my share of pretty intense physical pain on a chronic basis, neurogenic pain, very hard to manage. And there was a period in my life in my late teens, early adulthood, when I went through extreme psychological distress over a number of years, where I was basically dysfunctional. The suffering, I'll take the physical pain any day over the emotional anguish I suffered for 2 years, any day. That suffering was intolerable for me. Whereas I can tolerate extreme pain for days on end because but emotional, psychological, profound distress that can't be palliated. So somehow the sense of, well, if you're suffering psychologically, that's not so bad. Really? Where do you get off saying that? That's usually said by people who haven't suffered tremendously psychologically, because you can't see it. We're very, concrete thinkers. Oh, I see the wound. I see you crying. You're in pain. But if you look okay, then you can't be really suffering. Well, that's ridiculous. So I don't buy that argument. But I do believe, I think there is a slippery slope. It's just not the one everybody's talking about.
Yeah.
So I don't think the slippery slope is because we're going to extend it to some minors or people with psychological distress. I frankly don't care how old you are or what you're suffering from. I don't think certain people should be entitled to have their extreme suffering relieved and others shouldn't be. That makes no sense to me. Where I think there's a slippery slope is on my other point, where we don't have the checks and balances we used to have. We do not have confidence in our health professionals to make difficult judgment calls, right? You can't say to a family member, well, she's not suffering that bad, right? So, this is not an act of last resort. We could have easily palliated this one. So what I'm saying is the slippery slope was when we went from an act of last resort to it should be an option like any other option. So, when I talk to the physicians, I mean, frankly, we've had a real challenge lining up physicians who will do this, at least in what we call the English sector. I hate that term, but in the English hospital system, it's not like the doctors are lining up around the block to perform medical aid in dying. It's really hard to recruit them. But those I speak to said, well, I was willing to consider doing it when I thought this was going to be, for my patient, in extremis, as an act of last resort.
Yeah.
I didn't sign up to provide this for people who said, life sucks. I'm 85. I'm alone. Nobody likes me. I'm on welfare. I'm stuck in the CIUSSS all day looking out the lights, out the window. I'm going to get COVID next year anyways. What the heck? Let me just go. I didn't sign up for that. So to me, the slippery slope is, where's the checks and balances or decisions of what we wanted? Now, if society and the legislators say, we want this as an option, like any other option, well, fine, then the population has spoken and legislation has spoken. But that's, to me, a slippery slope from active last resort on a moral basis, plain. I'm not saying it's worse or better, but morally, they're very different. Morally, an active last resort is not the same cup of tea as pick and choose. You want chemotherapy, you want to stop this, you want medical aid in dying, pick one, check the menu, and you have it. They're not morally the same to me.
Yeah.
Right. Very interesting. Just before we close, Dr. Bereza, I'd be interested to know if you've ever dealt with a case of assisted dying where loved ones regretted the decision to intervene in the death process.
Let me think for a sec. Surprisingly, no. I'll tell you why. I mean, that doesn't mean they don't exist. I just haven't seen them.
Okay.
I think I haven't seen them because at times so let's take a paradigm case, right? A paradigm case is where medical aid, restrict this to the medical aid in dying as opposed to withdrawal of care. Patient has decided, I've seen many of these cases, patient has decided they are ready, they meet the criteria and they want it. But the family, the daughters, the sons, they also be saying, this is crazy. That's not our mom. Our mom raised us in this particular cultural / religious ethos that could never have agreed to this. So she must be ill, or she must be psychotic, or she must be under the influence. But there's no way I'm going to do everything to make sure she doesn't get this. Now, the law is clear. It doesn't really matter what the family wants. It's only what the patient wants. But those family members that I've seen have never regretted making a big fuss about it because ideologically, they're so sure that this is a terrible thing to do.
Uh-huh.
So it's not like they've come around at the end saying, oh, I guess I was wrong. No, it's a profound moral position for them.
Right. Okay.
So,
right.
But
which is there irrespective of the circumstances.
Yeah. Now, again, I'm sure there must be some people who have been changed by that. In fact, I do know one individual, a key person I know who was in politics who was very much against medical aid in dying initially, and then saw a loved one, close family member, go through a difficult death where palliative care didn't seem to be able to provide the relief necessary. And having watched this beloved family member go through that kind of death, suddenly became a pro-MAID person. So it does change some people.
Right. Okay. Thank you.
You're welcome.
Thanks to the three of you for an enormously stimulating conversation, wide-ranging, covering many, many different topics and questions regarding MAID and the ethics of dying. I would like to invite our audience to submit questions. And as we wait for those questions to come in, I've got a couple of questions of my own that I'd like to float just for to see if I could continue the conversation. I recently heard about a 95-year-old person. This is a concrete sort of instance, a case, who was accepted into the MAID program on the basis of concerns about his future loss of autonomy, and as he saw it, the associated loss of dignity. He did not have a terminal diagnosis, and I don't believe that his physical suffering was a factor. He lived alone and had begun to have some difficulty showering and dressing on his own. His story caused me to wonder whether his application would have been accepted had he been 85 or 75 or 65, and also to wonder about whether decisions about applications to MAID are taken on the basis of, let's call it, a normative conception of the life course and of the possibility for happiness at different ages. Could you comment on that, Dr. Bereza?
Okay, I'll try my best. I mean, the standard answer is no, I won't comment on that case because I've been burned too many times commenting on a case and there's a new detail that pops up which changes the whole calculus, right?
Of course.
But I will say, let me answer it this way. Even the best laid rules and legislatures are not perfect. And what we struggled with, I've seen physicians involved in MAID who struggled with this, nurses who struggled with this, and I've even seen members of the commission who struggle with this. There inevitably are gray zones. Gray zones where you go, what am I supposed to do with this case? I'll give you an example. So, and again, I'm not trying to, make this less important than it is, but, I remember, let me give you a different kind of, so in that case, based on what you described, I don't think the person, frankly, would meet the requirements today. That's my sense, unless they're missing something, okay? But let's say I was aware of a case where I had an 85-year-old who had a whole bunch of common illnesses we see at that age, you know. Certainly was frail, very frail, had severe arthritis, had severe diabetes, had a whole bunch of, none of which in and of themselves could be said to be life-ending, imminently, right? And then he fell down and he, you know, this is Montreal, black ice, everybody knows, February.
Right.
If you're 85, you fall down and break your hip in Montreal, that's a death sentence. I'm not joking.
Mm-hmm.
Right? You don't, not because your hip is broken, but because at 95, you're usually malnutrition, your recovery rate's so poor, you're gonna get some kind of infection in the hospital. You'll never leave. Now, I'm being morbid. Of course, some leave, but the prognosis actually for those individuals is poor. So if you showed me a 95-year-old with severe arthritis, uncontrollable diabetes, hypertension, chronic fatigue syndrome, and a broken hip, I wouldn't be able to check off the boxes. But I know as a clinician, his prognosis is worse than the guy who happens to have stage 3 cancer. So to say him, sorry, you don't check the boxes, you know, you don't have a specific diagnosis which tells me you are going to die within a year from this disease, right? That's a disease-oriented model. As a family physician, I look at the whole person. I add it all up and I say, what is the prognosis for you, not for the disease? And so there's some patients which I think medical aid and dying providers have felt bad about because they are convinced that that patient is as much vulnerable to dying and is suffering as much as people who do strictly meet the criteria. An even more blatant example, there was a few cases where, well reported in literature, where physicians were sent a letter saying, oh, you broke the law, you provided MAID. Why? Because the patient met all the criteria except their Medicare card was not validated. You know, well, go to jail, you're committed murder, you know? I mean, really? You broke the law. Why didn't you renew his Medicare card? Oh, well, we were busy. So yes, I think my answer to your question is I wouldn't be surprised if there are cases that are pushing the boundaries all the time. Absolutely. I personally, I'm worried about those cases of not just the extreme elderly, but of the homeless, the disadvantaged, you know, all those marginalized people. They are, what do we do with them? And now they're asking for medical aid and dying. Hey, you know, that's what I'm worried about.
Thank you. I'd like to return to your comments about the slippery slope and the act of last resort. And I'd like to do so in reference to an article that I think was shared for this evening's webinar, the David Brooks article from Atlantic in the month of June, right? In which he takes on our MAID program. And he makes a number of statements about Canada. And I wanted to get your response to the claims that he was making. And I'll read just 4 snippets, really, that sort of capture the argument that he was wanting to make, right? Canadian society apparently had no shared set of morals that would justify saying no to the question when people who were suffering applied to the MAID program, and I said, I choose to die, right? Within a few years, Canada went from being a country that had banned assisted suicide to being one of the loosest regimes in the world. Next, a healthy society builds arrangements and passes laws that make it easier to fulfill the obligations that come with our gifts. A diseased society, implying he was referring to Canada, right, passes laws that make it easier to abandon them. And last, what troubles me is Canada's rapid expansion of its law beyond its originally well-defined limits. That's a failure of public philosophy. Law ought to venerate life above individual choice. American states such as Oregon that have assisted suicide laws have not experienced the slippery slope I identify because people have set reasonable limits on their programs. In the years to come, I'm hopeful that Canada will do the same.
I'll try to answer it this way. And I'm not trying to pass the buck here. I think there are parts of each argument which are sustainable and other parts which I'm a little dubious about. So in and of itself, one argument on its own, parts of it make sense and parts don't. I'm always nervous, and I don't know the author personally, so I want to depersonalize this.
Yeah.
What I see often in the literature, and again, it is usually a polarized debate. And so what I see people often doing, and it's like, I think you would agree with me, it's a classical approach in philosophy, how we do this, is you pick a position and then you selectively pick those arguments which support your position. So if you're somebody who really finds medical aid in dying morally challenging, and now you're seeing it extended, you're going to selectively pick arguments, say, see. And I see that on both sides of the arguments, right? So I'm always nervous when people make claims without being able to validate it. You're entitled to an impression, but where's the proof for these statements? They may be plausible, but how do I know they're true? So, and again, you say, well, yeah, it's not that I disagree. The situation about we should, there's a normative statement there which says we should, if I heard you correctly, venerate life above personal choice. Right? I think that was the wording. Now, again, I don't know the author, and I'm sure it's meant properly, so I don't want to cast aspersions in any way here. But said by somebody else, you could see how that could be an absolutism. You know, we're going to have to venerate life above personal choice. So you mean I have to stay alive because you think life is more important than my personal choice? Who the hell are you to tell me that? So if you want that, fine, do it for you. But why are you imposing that on me? You are so convinced that the veneration of all life, always, under all circumstances is so great that you're prepared to impose that on all of society. And where is the evidence that you're right? So that's where I get a little bit nervous, you know?
That's very helpful. Thank you. I'll go to some of the questions now that have appeared in the chat box. First, how can someone be found not guilty by reason of insanity, yet still be competent to ask for aid?
Sure. So again, I'm not a psychiatrist, but in my experience, competency is, there's a couple of things to say about competency. Competency is not a all or nothing, right? Competency is usually seen, at least legally and clinically, as task specific. So we know individuals who may not be able to balance their bank account. They're incompetent to balance their money, but they can still cook their breakfast, they can still get up, tie their shoes, they can still do their acts of daily living. We know there are individuals who can't do their acts of daily living, but can still do X. So competency, just because you're criminally insane on one thing, doesn't mean you've lost all competency in all matters. Okay, so that's number one. Competency is usually defined on a task-specific thing. You can still remain competent to make decisions about your own life and your own health care, even though you're criminally insane about other issues. That's number one. And number two is competency has to be also understood in terms of timeframes, right? When we, at least in the clinical world and legally, commit somebody because they're incompetent, we have to lock them up, so to speak. It's time limited. I can only keep you for as long as you are a danger to yourself or others. Many people go through a short period and then they become competent again. If they have a psychotic breakdown, we treat them and bang, they're okay, or relatively okay. So you can be competent in some things, not in others, and you can be incompetent on Tuesday, incompetent next Friday. So those are factors to consider. It's not a ubiquitous one size fits all everything for everybody notion.
Thank you. Another question. Can you give us a sense of how far palliative care can go in alleviating suffering?
I'm having a little trouble saying what do you mean by how far?
That's the wording here, so we need to extrapolate from that.
Yeah, I'll do my best. Again, I'm not up on the latest in palliative care, but I have to say when I was interfacing with my palliative care colleagues, I was impressed with just how much you can palliate. I mean, so much is available now that wasn't available 50 years ago in terms of technique, know-how, medications, alternative therapies. There's a lot that can be done. And I think there's a significant literature that demonstrates that excellent palliative care in the proper hands and the proper settings can really palliate probably, I would say, most people most of the time.
Okay. You acknowledged earlier that you're not a psychiatrist, so I'll read the next question with that in mind, right?
Okay.
Psychological pain is absolutely as devastating as physical pain, but people don't die of psychological conditions. They may succumb to suicide. Are there really cases of psychological distress where there is no hope of future treatment options?
So I think the answer is yes. There are now, having said that, and again, I'm hardly an expert in this area, but in my limited knowledge, there are cases, but very, very, very few, relatively speaking, cases. I know that I remember at the time when I was much more on top of the literature, there were cases in the Netherlands, I believe, where a handful, I mean, really 4 or 5 patients over a course of many years who were suffering from severe psychiatric illness, like a severe depression. These were patients who underwent first, I mean, it was an active last resort because they underwent all the treatment options that you could throw at them over a course of many years through many different psychiatrists. I mean, they kept being bumped into more and more and more subspecialists with, focusing on every time. And these were called refractory. No matter what you did for them, there seemed to be nothing that could help them improve. Their anguish was refractory. Now, I don't think that's the norm. That let's keep in mind, this is the extreme outlier, but they exist. In my entire clinical career of 33 years, now again, I'm not a family physician. I was mostly in medical ethics, but I've had thousands of cases I've been involved in. I personally have only seen 2, but I have seen 2 patients who had been under intensive psychiatric care by a whole host of institutions and psychiatrists and alternative therapies over a course of decades, with no improvement and in fact continued decline and suffering. And so yeah, they perform suicide because that's their only option. In that regard, for them, the final end point, I mean, again, they're framing it as my only endpoint to alleviate the suffering is death, because that's the end point of severe depression. It's refractory. So I think it's possible, a very rare number of documented cases, and that's as much as I know.
Thank you. How is MAID different from giving palliative sedation to cause death?
Yes. Okay. Good point. And depending on your point of view, now there's sort of some people say, well, now you're really splitting hairs here. And palliative sedation, the idea there is when the physician provides you the medication to sedate you, the intention is not to provoke immediate death, right? But if a physician does MAID, I inject you with the cocktail or protocol, and I'm saying within 15 to 30 minutes, you're dead. Palliative sedation, the idea is a patient says, okay, I don't want that for moral or religious or cultural reasons. I don't want that, but I don't want to be conscious of the dying process. It's not just the pain. I just knock me out, snow me, as they say. So we sedate you and we keep you sedated so that you never regain consciousness. Mm-hmm. Now, what we don't talk about often is there's a 1-2 punch here. If we're going to do that, typically, and the Quebec legislation on that restricted it so that you're only supposed to be providing that for patients that are within their last few weeks of life. Okay. And what normally happens there is, well, you can imagine if you're completely unconscious, well, then you're not exactly using your hands to eat a hamburger. So no food and fluids. and you've probably refused consent for medically provided food and fluids. So certainly the combination of imminently dying from, let's say, your cancer, you have 2 weeks left to live, and the probable dehydration and malnutrition that you're going to die from that. You're not dying from the protocol of medications, which are going to cause immediate death. That's the distinction.
Mhm. Thank you. The next one. I have several elderly acquaintances in CHSLDs who get depressed or seem to feel guilty about the care their families are providing and go for MAID. I can't help feeling that the poor care we offer elders and how old we are living now are pushing people to end their lives. Please comment.
I can't disagree with that. But again, it's an impression. I'm pretty confident, but again, I look around, everybody I speak to, all the colleagues I speak to at the hospital or at the CLSCs, almost to a person, nurses, doctors, social workers, they all say to me, you're right, Eugene, we've never seen the healthcare system as bad in the last 3.5 decades as it is today. So my personal view is that's true. My personal view is we've not figured out how to provide the care we need for everybody who needs it in a way which is appropriate. And so, but that's the reality. So one answer is, well, that's terrible. We should change that back to the good old days where we're going to, have a massive influx of new funding and we're going to fix everything. Remember that in Quebec, the last time I checked, we were spending close to 49% of the entire provincial budget on healthcare.
Wow.
Well, how much more do you want to spend on healthcare? Half of the entire budget is going to healthcare. You want to spend 80%? Well, then you got to give up the roads. Well, guess what? We will have more potholes. There's limits to how much you're going to spend. So we haven't figured out what to do, but I'm wondering if we haven't come to the point, decades after Medicare was introduced, the concept of it, where, it was originally intended, we're going to provide everything for everybody. We can't afford to do that anymore. That's the reality. Do I see a silver lining on the cloud where within the next 10 years that will change? No. Now, if I'm right, and I'm guessing, then that's the reality. That's the context. So, as somebody working in applied ethics, if that's the reality, those are the conditions under which you're working, what are you supposed to do as a clinician with a patient who comes to you with that complaint? To say, well, Canada should figure it out and provide better access to better care for everybody. We have a terrible reputation for providing access for mental health, Indigenous community. I mean, the list is endless, and you all know people who can't get access to care. How many Quebecers have a family doctor? So if I can't change that, that's the reality, the box you have to work within. And if you're so yes, I agree. There are probably psychosocial factors that play a heavy role now in people's deliberations about asking for MAID. Is that good? I think that's terrible. Can I do anything about that? No. So figure out what you're going to do within the parameters that you have and judge accordingly.
Right. Second to last question.
Okay.
Why does Quebec have a higher percentage of MAID compared to the rest of Canada?
Oh my gosh, this is an area of great interest for me. Nobody has given me a good answer. We have to keep in mind that we're not completely alone. My understanding is BC is kind of either close behind us or at times even edging ahead of us, depending on the year. So BC is pretty well up there as well. But yes, definitely Quebec is at the forefront. I don't know. I've spoken to anthropologists and psychologists and all kinds of sociologists, but I haven't seen any convincing rationale. People make all kinds of claims. Some say, oh, some of it is because of the rural francophone culture, we shoot horses, don't they? We don't let our animals suffer. It's a part of life. What's the big deal? I have no idea why that is, but others have claimed that.
Do you have any hunches of your own? In the absence of research or evidence, do you have any hunches?
I have a sense that there's a cultural component here, but I can't be more specific than that. I think it has to, we've been known not just to be at the cutting edge, for lack of a better word, not just for medical aid and dying, but remember in the old days when it came to abortion, Quebec was also at the forefront of that. So Quebec is often seen as the revolutionary forefront on a lot of social controversial issues. Why is that the case? Why is Amsterdam, Amsterdam? I don't know.
Yeah. Our last question then is, in view of the major problems with access to care for even basic care in Canada, does it make sense morally to offer MAID to people who have treatable conditions but no access to services?
No, again, morally, I find that horribly problematic. I mean, for me personally, my moral compass, but that's clearly, I'm probably an outlier. I'm not representative of population nor of the legislation. My moral compass says there's something wrong morally about the fact that we're not going to let you get access to good care. But, if you're get really sick about that or suffer because of that, and that's a consequence of it, and if you want medical aid and dying, we'll take care of you that way. That really does not sit well morally at all. Having said that, so life's not fair. Life's not good. It's like we said about palliative care. Not everybody's going to die a good death. Can't fix everything. So I'm not excusing it. I'm not justifying it. I'm saying the real challenge is, what do you do with what you have? And to say, oh, it's terrible. Yeah, it's terrible. Can we get on now with what are we going to do about this? It's been terrible for a while and it's going to get worse before it gets better. So it's wrong. It's wrong for me morally that people get MAID but can't get basic care. There's something wrong with that. But, politicians are aware of this at every level. And if you want a provocative statement, I have colleagues and family members who live in different parts of the world. And when they hear about how bad it's gotten here, they say, how is it that Quebecers aren't out on the streets marching in protest saying, what's happened to our healthcare system? Almost everybody must know somebody who either doesn't have access or has suffered or had to wait for cancer surgery. We all know somebody who's not getting what would have been considered a standard of care 2 decades ago. Mm-hmm. And we seem to be complaining, oh, well, that's bad. That's bad. But you don't see this major revolution of going out there and say, guys, everybody, federal, provincial, they all throw their arms up and say, well, we've tried to fix it. We don't know how to fix it. It's complicated. We'll try this. We'll try that. New Minister of Health comes in, sweeping reforms, spend a couple of $1 billion trying to fix it. It fails. New regime comes in. Let's try this. Sweeping reforms. It's being impossible. I don't know. I'm pessimistic, unfortunately, on that one.
Danny, just before closing out the evening and thanking our guest, I'd just like to mention 2 things with respect to Dr. Bereza. First of all, I know he has a very significant birthday just around the corner, so I'd like to wish him a very happy birthday. And secondly, he's not only a music therapist, he's a performing musician, and he's giving a piano recital at the Unitarian Church in Montreal on the Maisonneuve Boulevard on Saturday at 7:30. So if anybody wants to hear some really good classical piano, by all means attend.
It's $5,000 a ticket for those of you. It's sold out. It's sold out. Anyways, I appreciate the invitation and I appreciate the questions. It was really a nice interfacing with you. So thank you for that opportunity.
Thank
Thank
you.
you for being with us this evening, Eugene. I called you Dr. Bereza at the outset. I'm going to call you Eugene at the very end. Thank you so much for being with us.
My pleasure, anytime. Thank you very much.
Thank you, Eugene. Thank you.
Thank you, everybody, and thank you to all our participants too.